This presentation is to elaborate on a new and evolutionary treatment for the big overbite. It is called IMDO. We live in a time of real clinical revolution, where as clinicians we are no longer held back by insufficient data. We can now see malocclusion in an accurately visual and interactive dynamic. This allows us to see how we can precisely manipulate teeth through orthodontic and surgical means, and of course how we can change an entire occlusion through the pioneering process of IMDO. It is said that a picture tells 1,000 words, so here they are. The changing occlusion of a young boy from 14 through to 17 years of age, made possible by IMDO, and eventually resulting, hopefully, in the healthy, lifelong retention of all of his teeth. This is the underside of the skull, and we're seeing the expansion of the maxilla first and the means by which that is done, by an RME device. This is followed by the application of the IMDO tesseract distractors to the small lower jaw. Distraction occurs three-dimensionally, widening as well as advancing the mandibular occlusion, giving opportunity for a simpler style of orthodontics and for natural dentalveolar growth, unencumbered by the original small size of the lower jaw, to create an optimized occlusion. And by comparing the 14 and 17-year-old mandibles, you can see the conformational changes that are occurring to the body of the mandible itself, with effective widening and advancement of the mandibular body, the squaring of the mandible, the changing occlusion, the advancing chin point, and the wider cheekbones. And by this series, we can see the three main principles of management being maxillary expansion, mandibular distraction, and natural growth and dental settling. Three-quarter view, our insight of mandibular hypoplasia takes account of the narrow midface, the small mandible, and the class 2 malocclusion. Once all the baby teeth are lost, maxillary expansion can begin with the orthodontist. This process takes about 6 weeks and is followed by the application of the distractors in a 40-minute procedure. These are extended at home 1 mm a day by the child's parents, producing the three-dimensional changes that enable for natural tooth eruption, eventually perfected in their positions by the use of braces. Distractors are typically removed at day 42, and bone consolidation is completed by 3 months, with the entire treatment process lasting 2 to 4 months, with braces following a short time afterwards. Whilst facial growth might have stopped, dentalveolar growth continues for much longer, and we give the greatest potential to retain all teeth as nature intended. How we see that transition from abnormality to normality can be enabled by this new dynamic of management of insight seen here in this timeline to elaborate our treatment themes of maxillary expansion, mandibular distraction, and natural growth and braces, and again comparing these changes to what we originally saw with the underside view of the face and skull. But the big question is everything aimed at simply treating a dental overbite? Here is Patrick, and he is 14 years old. He is in Year 9 at high school, a boy who is still growing, but who has not quite finished growth. And here he is now older by 30 days, and we can see some radical changes have occurred to his profile, but let's go back to the beginning. Patrick, all his recent life, suffers from neck posture issues, a diminutive chin, poor lip posture, poor eating, and the visual appearance of a big overbite. Modern imaging technology enables us to see the whole picture, including his vertebral posture, his bite, and of course his face. But as dentists, we can choose to look only at teeth, and if that's the case, let's focus on Patrick's occlusion, the degree of his dental overbite, and the interrelationship of his upper and lower dental arches. And in this way, we can elaborate on the dental effects of his treatment by IMDO. We start with upper dental arch expansion using an expansion device, which can dramatically widen the upper arch of teeth. We call the device an RME, or Rapid Maxillary Expander. My preferred term is the hyrax. But these effects go beyond dental. They are skeletal as well, as shown in this underside view of the skull base. What we can see is that maxillary expansion also widens the cheekbones, separating the mid-palatal suture. But far more is the effect on the nasal airway, which also expands with the mid-facial bones. You can see the airway here in blue, occupying the maxillary sinuses and the middle face, and that widen and enlarge as the mid-face also enlarges. We can measure the nasal air volume changes beginning at 94 cubic centimeters and ending at nearly 100 cubic centimeters. These are measurable and consistent and predictable changes using this basic therapy, giving a total expansion difference of almost 6%, with a total expansion across the maxilla of close to 9 millimeters. By increasing the physical size of the upper arch of teeth, there is the impression that the overbite has been made worse, that the upper bite is now too wide, that the upper front teeth are too forward. But with the application of IMDO tesseract distractors to the lower teeth, we can advance the lower teeth forward to correct the dental overjet by almost 12 millimeters. And widen the lower arch of teeth as well, a further 6 millimeters, matching the new dimensions of the upper arch of teeth pre-widened by our hyrax. This gives an almost universally asymmetrical, and in Patrick's case an average, total distractor separation of almost 13 millimeters. Our measurements can also apply to seeing also the physical change in the size of the mandible, seen here to begin at 38 cubic centimeters, expanding through distraction to a normalized 48 cubic centimeters, accounting for a 27% volumetric change from the original size of the mandible. Of course, as the mandible widens and lengthens, it also tents out the oropharyngeal airway through advancing the hyoid and epiglottis. We can measure the oral air volumes very precisely, seeing a volumetric change that replicates the volume change for the mandible, giving a similar expansion value of almost 27%. By collating the oropharyngeal and nasopharyngeal airways together, we can see the overall relationship of upper airway to the occlusion, as well as to the calvarium, and also to the vertebra, giving a relativistic sense that the small lower jaw does not exist in isolation, but that mandibular hypoplasia also affects things such as vertebral posture as well as airway volumes, and that as a construct we can see the entire anatomy of his neck, skull, mandible and teeth that together makes up our subjective of the facial profile. And when we do apply the mandibular distractors and orthodontically expand the upper jaw, we can see how our surgical and orthodontic interventions come to radically transform not only mandibular volume and the occlusion, but that it also has dramatic effects on the vertebral posturing and hyoid and epiglottal position, and with radical transformations that occur to the facial profile, seen here in transition views over 30 days. It is these transitions that helps give us as clinicians and as patients the most meaning and the greatest relevance to the obvious changes in chin position, lip posture, submental angle, and overall neck position. Traditionally, orthodontics is far more interested in assessing these changes through the simplicity and 20th century classical two-dimensional lateral cephalometric view. Using these simple X-rays, we can make some subjective, but nonetheless I believe subjectively meaningful assessments through transition animation as seen here. Or we may be more objective, more scientific, less meaningful I believe than by digital transitional or volumetric accounts, but we can still take a limited set of formal measurements, such as by measuring SMB angle difference, or changes to anterior facial height, or by measuring mandibular length. But I think the relevance of these measurements are outdated today. But it's the patient's perspective that takes precedence. It's a real account of real changes, of real facial transformations, all occurring by these simple interventions, without just considering the singularity of profile, but by considering everything simultaneously from the collarbones up, across all visual angles. These transitions that I demonstrate here are just 4 weeks apart. I know that as dentists, we're far more interested in the changes which are occurring in the occlusion, seen here without a traditional primary intervention by orthodontics, but instead through the primacy of surgery and by facial orthopedics. What I mean to say is that we are treating our patients earlier, at younger ages, and that this condition of dental overbite is far more than a malocclusion, and that what we are doing is correcting the cause of the malocclusion early, and we are doing it by making both of the jaws and both of the dental arches and the airways and the lower face, all of it, bigger. The maxillary expander and the mandibular distractors are combined, forming a complex 4-dimensional change to the occlusion across both jaws and across the entirety of the face. This is followed by a natural dental settling, and later again with the addition of much more simplified and a much shorter course of orthodontic treatment by Class 1, not Class 2 orthodontics. And overall, this combined process maximizes the potential of combining surgery with orthodontics. It's a more dynamic interrelationship, and here we are, seeing the effects of that relationship transitioned over 6 months. In summary, our process begins not so much with a dental diagnosis of malocclusion, but instead with a medical diagnosis of a skeletal and facial and airway undergrowth. It begins with the antithetical premise of making the maxilla bigger, reliant upon the absolute predictability that lower jaw distraction can correct the mandibular hypoplasia and also the fundamental nature of the malocclusion, giving way to a skeletal and occlusal template that maximizes natural occlusion settling and the opportunity for orthodontics to truly acquire occlusion normality. But it is not just malocclusion, it's also the face and the airway and the posture, and finally and most importantly, we are correcting the very confidence of the child. Thank you.